Hi everyone, how are you? I'm Christian Navarrete from Santiago, Chile, and I'm happy to be here. I mean, being online is not the same, but I hope you're enjoying this great dermoscopy meeting. I saw the program and I think it's really, really good. I hope you're learning a lot. And continuing with dermoscopy, we're now going to discuss about entodermoscopy or dermoscopy of infectious diseases, okay? So let's see how this is. I have no conflicts of interest. And again, I will show this photo because I think it's great to see how medicine used to be practiced, right? You can see here this guy listening to this poor sick person, this patient here, just with the ear on the chest, right? Without a stethoscope. So this is the way medicine was practiced back in the day, right? Then René Laennec invented the stethoscope and everything changed. And I think it's the same for dermoscopy, right? I think as this paper shows here, that the dermatology stethoscope should be, and it is now to me, the dermatoscope, right? This using dermoscopy. And I think in general dermatology and of course, in skin cancer, dermoscopy must be part of your daily uses. And I think, again, it helps you focus on the disease. It's different to see a patient from far away than really focus on the patterns using your dermatoscope. I think you can really see better the pattern if it is a squamous disease or a eczematous disease. I think it's much easier with your dermatoscope. Again, nowadays I can't examine any patient without my dermatoscope. I practice in a melanoma unit, right? So there's no way I will see a patient without a dermatoscope. But even when the patients have rashes or dermatitis, whatever, I always use my dermatoscope. And it really has guided me to the correct diagnosis. And some of these examples here are going to show you that. And I think you're going to cover some of these talks here. I'm not covering any of these, but entodermoscopy. But I think if you like these, I really encourage you to open your books and read about cosmetic dermatology and dermoscopy, about surgery, lasers, etc., etc. And I think it's anything you like. So what is entodermoscopy, the topic of this talk? It comes from the Greek word entomon, which means insect, and scopion, that means to look, right? So this is just using the dermatoscope for the diagnosis of the diverse infectious diseases. And let's be honest, dermatologists have been practicing for years without a dermatoscope, and we are pretty good at doing diagnosis just with our naked eyes. But believe me, occasionally, many of these infectious diseases can simulate other dermatoses, so dermoscopy can really help you, or at least will narrow your differential diagnosis. And as I was telling you, I don't examine any patient without my dermatoscope. This is an article for the GADV from 2022 that just shows how many terms have been used for entodermoscopy and that the terms are not uniform and that there's need to be more standardization on this topic. But if you look at this list of terms, these are everything that has been described for general dermatology, for infectious diseases with dermoscopy. And if you want to read more about this is the paper, you can take a look about it. So let's start with the first disease. Let's learn about scabies, which I think is the classic one for dermoscopy. So you all know what scabies is, these infectious diseases that is caused by direct skin to skin contact. Of course, patients have pruritus of the sheath complaint, and common sites are the hands, of course here the wrist, the umbilicus or periumbilical area, the inframammary folds, and the genital area. And classically, diagnosis has been made by skin scraping, right? With classic microscope view, KOH, or whatever you use. So that's how diagnosis was made back in the day, right? But nowadays, I think dermoscopy is just enough for the diagnosis. I haven't used any skin scraping for years, right? I think I've been using dermoscopy in every patient that I've suspected scabies, and so far I've been doing very well. That's what I think. So what are the dermoscopic findings of scabies? And I think the delta sign. And this is something you need to learn that is very important. This is just a small triangular shaped brown structure that represents the anterior third of the mite. It's just the head, the mouth, and the frontal two legs of the mite. More than 95% of the time, this delta triangular sign here is associated with this burrow or the contrail jet, this wide hyperkeratotic linear structure behind the delta sign. Remember that you can only see the anterior third of the mite due to slight pigmentation of this mite, because the posterior parts are transparent, so you can't see it with your 10x dermoscopy. But nowadays, with the high magnification and with digital dermoscopy, you sometimes can see the whole body of the mite. It's easy to perform, it's non-painful, and you don't need sharps, so even in childs you can use this. These are a representation of the mite under a classic microscope view. These represent the delta sign. This is the invisible part, and this is the contrail or the burrow, right? And there are many names for these: delta glider, hand glider, delta jet with contrail, etc., etc. But what is the accuracy of dermoscopy for diagnosing scabies? This is a study from France. It's a bit old, it's more than 10 years old, but it's a great study. It was more than 200 patients, and they compared the delta sign with dermoscopy versus skin scraping, which was the gold standard, right? The sensitivity of dermoscopy was 91%. The specificity of skin scraping was 90%. And the specificity of dermoscopy was 86%. And for the classic microscopic view was 100%, because that was the gold standard, at least, or assumed gold standard. Negative predictive value was 90%, similar for both, and positive predictive value was 88% for dermoscopy. This is very interesting. The performance, the specificity, improves with training. So novices had an 80%, but experts had a 93%, because there are many false positive, crust, excoriations, so you need practice to learn to recognize the delta sign. And here you can see in blue the expert, in orange the non-experts. You can see how the specificity is fairly different between experts in blue and non-experts in orange, right? And you can see here how the non-expert dermatologists improve across their specificity while they were learning more and more dermoscopy. So this is something you can train and you become better and better. I'm going to show you a case. This is a healthy male in his 60s, 6-month history of these papules, itchy lesions. It was treated as scabies, not a correct treatment, but like some sort of treatment. It was not improving. These were the lesions here. So they did a biopsy, okay? So the patient came to me with a biopsy that was done to rule out LYP, lymphomatoid papulosis. And of course, biopsy came back as lymphomatoid papulosis, right? This is the classic findings of lymphomatoid papulosis. So the question is, does this patient has LYP, right? The patient was waiting to start on phototherapy or methotrexate back in that day. So I said, let's take another look before starting any treatment, right? Again, this is the patient. Look at this lesion here, circle in this marking. You can see here that lesion. With this magnification, you some sort of see this linear structure, but now we use our dermatoscope, right? And what do we see here? This is the way you see it with your eyes without magnification. You always learn from the books and you see this huge delta sign. This is the real size, right? So this tiny, tiny area here, I'm going to zoom it for you. Tiny area here, more zoom for you. And you see here the triangular shape delta sign. This is the invisible part I was telling you. When you zoom in, sometimes you see it. And this is the burrow of scabies. And this was a classic delta sign. So this was scabies, incorrectly treated. Patient was treated with oral treatment and is super good. And it was just a pseudo-lymphomatoid reaction to scabies. More cases, okay? This is a patient, again, treated by a systemic cancer with chemotherapy, came with this rash, and look at this. You have here delta sign, contrail, delta sign, contrail. I'm going to zoom it for you. You have here clear delta sign, and the contrail. Patient, again, coming from a vacation in Europe, and this widespread rash, very pruritic, and the patient came to us. And we found this lesion here on the sole, right? And you can see here with this magnification, this linear structure, which is the burrow, right? And here you see the delta sign, very small, as I was telling you. Another area of the same patient, the wrist, classic area. You have here the contrail, delta sign, zooming in for you, delta sign. So I'm going to just highlight for you again this is how you see the delta sign without zoom, without magnification, with your eye. That's why the expert dermoscopists are better than the non-expert, right? Because it's very subtle. Could be very subtle. I'm gonna zoom it for you. And this is how we see it on the talks, right? On the books, on the papers, because nobody uses this photo from far away, right? Everyone uses this zoom in photo to show delta sign and the glider. And I was telling you, the main issue is specificity, because you confuse delta sign with the crust. But UV dermoscopy can help you improve your specificity. Not a nice photo, but a patient with scabies, right? This is the classic delta sign again. This is the burrow. But what if we use UV dermoscopy, right? And with UV dermoscopy, this mite has this fluorescent green color, yellow-green, some people have called this. And you have also the hyperkeratosis, which has this fluorescence also on the back. So this improves a lot the specificity, because crust won't have this green color, right? You can increase your specificity by using UV dermoscopy. Patient, we published this, right? If you're gonna read more about this. This is a patient that has a darker skin type. And on darker skin types, sometimes the delta sign is harder because it's dark, and also with the darker skin, there's no contrast, right? So look at this patient of ours, Latino patient with these burrows here. As I was showing you here, the delta sign, you can confuse this with the background skin. The burrow is different, but with UV dermoscopy, boom, easy. You see this green fluorescent coloration here that is classic of scabies. Another example here, you have this lighter skin patient, delta sign, and you see this green mite here with UV dermoscopy and the fluorescent burrow. Again, you can keep reading about this, but it's very important. Why is it fluorescent, right? I was trying to understand this. And there's likely some sort of hyaline structures in the exoskeleton of these mites that gives this UV fluorescence. And this is a scorpion from Arizona. And one of our friends from Arizona was kind enough to capture one of these guys and put their dermatoscope, a UV dermatoscope. You can see it's the same green fluorescence. So I think it's something similar, right? Let's move now to crab lice or pediculosis pubis, right? Again, you know all this. I'm not going to focus on this. So just showing you that the classic diagnosis of crab lice was the direct visualization of the adults and nymphs or the eggs under a microscope. But look what happens with a dermatoscope. Boom, 1 second. Why do you need anything for this? You just see the lice here with your dermatoscope. So you don't need anything else, right? Let's take a look at a case. This is a male in his 30s. It's a healthy male. Came for this widespread pruritus. Was treated as dermatitis in another hospital. We topical steroids, no improvement. This is the patient. And you can understand why this patient was treated with steroids, right? These are just, eczematous plaques, right? Widespread plaques. Look at the back here. Look at here, the axilla is classic of, atopic dermatitis of the adult, whatever, right? But when we look carefully at this patient, look at the forearm here, we saw this tiny little, let's say, black dots, right? Is this contact dermatitis, atopic dermatitis? But what was going on there? Look at that. Use the dermatoscope. And this is 1 second, right? Let's see if this video works here. Yes, so you can see here. You see the crab lice. You see the crab lice eating. And you see crab lice, coming here. It's pooing, right? Doing the digestion here. And it's coming here. And you can see this guy, whenever you took it out of the body, trying to hold here to anything around, fighting for his life. So easy with dermoscopy, right? Look at this. There's nothing else. There's no false positive here, right? And even you see them live here, like Tarzan, right? Moving from hair to hair in the body of this guy. So it's very, very easy to make a correct diagnosis with your dermatoscope. Now we're moving to brown recluse spider bites, right? Or loxoscelism. Just FYI, this spider is very, very dangerous in South America. It, there are different species, but the South American one can cause a multi-organic failure, acute kidney injury. Patients go to ICU, so very, very dangerous. But in the United States, you do have the brown recluse spider. It's a bit less aggressive in terms of it causes only skin necrosis. Very, very, very weird to cause systemic reactions. But look at the map here. You know the southwest, not in Florida where you are now. You have the Loxosceles reclusa, which is fairly aggressive, right? And it can cause even death. Again, not common in the U.S., but yes, in South America and Latin America. This is a great paper by dermatologist David Swanson from Mayo Clinic, Arizona, which describes the mechanism of brown recluse spider bites. But what I want to show you now is how you can diagnose this. And this is a classic case in our practice in Chile, right? This is a young patient, 4 years old patient with an illusion on the leg. He thinks it's a brown recluse spider bite, and he brings something. Classic, right? Doctor, I brought you the spider. So the question is this really a spider bite, right? This is just a spider or just a piece of soil, right? Or an ant, a bee, I don't know what, right? So I always ask my patients, did you bring the spider, right? And the patient says, yes, take a look. And this is what the patients bring to us all the time, right? This is what this patient brought us, right? Just pieces of nothing, right? That's my face. And even if you zoom in, there's no way of knowing what this is, what type of spider this is, right? And one option is sending this for the entomologist, right? But it's not easy to find one here in my country. I don't know, in Florida, in your hospital, if you have entomologists 24/7, right? Very hard. So in the office, the question is, can dermoscopy help you distinguish harmful spiders from those that are not dangerous? And we published this a while ago, and I'm going to show you how to really tell them apart. So these are the pieces the patient brought us. This is a spider I found in my house, which is really non-harmful to you. So this is very important to learn. This is something you should memorize, and these are the different spider eye types. I'm just kidding. You just need to learn this, right? Only the brown recluse spider bite eye pattern, because it's the eye pattern that really tell us what spider is. So the brown recluse has this U-shaped 3 pair of eyes on the head that is classic of the brown recluse. This is the only thing you need to know. And what happens on dermoscopy? Boom. This is how you see it. Exactly the same. 1, 2, 3, 4, 5, 6. U-shaped pattern. That's it. What happens here? Oh, this is not a brown recluse. Look at this. 1, 2, 1, 2, and 2 up here. This is not the U-shape. This is just a different spider, a tiger spider. Another tiger spider. Look at this. Nothing here. 2 here, 2 here, 2 here. Not the same pattern, right? But what happens with the fragments of spider that the patient brought to me? Look at this. So easy, right? 1, 2, 3, 4, 5, 6. Boom. So the patient really had a spider bite. And 2 weeks later, he had this necrotic plaque here. Nothing happened. No systemic necrosis, right? But the patient indeed developed spider bite, right? And again, this is just for your knowledge. They are trying to develop a new assay for the detection of brown recluse on the blood. It's been a while. This is an ELISA test. I mean, it's happening, but so far, the only way of doing diagnosis and making a correct diagnosis is just with the visualization of the spider. And the only way of really be sure the spider is a brown recluse is by looking at the spider with the entomologist or with your scope. Next disease, gammasidosis or Dermanosis gallinae or chicken mites. So chicken mites. The first time I heard chicken mite was like 4 years ago. Never heard this during my residency, and maybe you have never heard of this, but this is an emerging disease. This is a disease that's happening more and more often, and I'm almost sure you're gonna see one of these patients once in your lifetime. So these chicken mites live in domestic birds, right? Again, in hen, in pigeons, in parrots, and they never attack humans, right? But in the last years, they're becoming more aggressive towards humans. In contrast to scabies, they don't live in the human; they just have this attack and run behavior, right? So you will not see the mites, the chicken mites, living on the body of the patient. They will go, they will bite, and they will go away, right? So look at this case. This was a healthy female in her 40s. Again, generalized pruritus, right? And the patient told me, I've seen insects walking in my house walls, the ceiling, and in my body. And the patient said, I brought you a container, doctor. Come on. This is a red flag, right? This patient is, I don't know, you will think is crazy, delusions, whatever, right? Let's take a look at the patient. So indeed, the patient had these erythematous papules, discrete, without burrow, without a delta sign. These were the hands, the wrists that were free. Dermoscopy, no delta signs, just this crust and these papules here, nothing. So let's take a look again at the clinical history, right? I was like, okay, show me your container. The patient said, it's here on my back, right? Take your time. That was me. I found it, doctor. I have a video too. And I said, let me see, right? But my diagnosis in my mind was delusions, parasitosis, right? I wasn't listening anymore. I was just, I have to refer this patient to the psychiatrist, right? But the moment the patient had the container to me, gave me the container, look what was inside. These were not pieces of soil, right? This was a real mite, right? Moving very fast, very quickly. So I picked one of these guys. I picked some of these guys. I put them on a micropore tape and adhesive tape, micropore. Look at this. You have here the mites. These small mites with 8 legs here. People have described this as a silver shining mite. More videos for you. Look at this. And the patient told me they were on the walls of their room, right? She was right. Look at this. This is her room. They were everywhere. Turns out this patient had a pigeon nest outside her apartment, right? So they came for fumigation, everything. They took out the nest and everything was happy and fine, right? So indeed, it wasn't the pigeons, right? I think the health minister came. It was a big mess after when I filed my complaint, right? And this is just a comparison between delusion of parasitosis and ectoparasitosis, like this one here, right? And again, patient brings a container. Yes, it's positive in delusion of parasitosis, and it's normally negative, with the exception of this case, right? This container sign, right? And this is another case we saw a couple of, I think 1 year ago, from a colleague of mine. Same story, but in this case, the mites were walking, crawling on the skin of the patient. So the patient was in the office with the chicken mites, and I think this patient was raising some parrots, whatever, I don't know. So this is gammacytosis or chicken mites. Let's move now to tinea nigra. And tinea nigra, I think, is important. It's not that uncommon, especially now we travel around the globe. I'm not sure if is it in the States. Yeah, they're on the beaches of the state, but it is indeed in the Caribbean, in Brazil. We don't have it here in Chile, but it's in many places, right? So this is superficial asymptomatic fungal infection of the scrotum corneum. It's classic of the acral sites. It's pigmented, and it's caused by this fungal Hortea or Neki, Asia, Africa, South and Central America. And you have this septa, this pigmented hyphae here in the scrotum corneum whenever you do a biopsy. Look at this example, pigmented macule here on the hand, and you have here in the dermoscopy these spicules. And these spicules don't follow any pattern. They don't have a ridge pattern, a furrow pattern. That's why you have this multi-direction spicules and this classic of tinea nigra, right? And if you do a small skin scraping, of course you'll see normal skin below, right? This is a great study from Australia where they show how dermoscopy improves the diagnosis of tinea nigra. These are 50 cases, and it's very interesting. These 50 patients, all with tinea nigra, diagnosis was suspected only in 14% of the cases based on naked eye examination. But when you use dermoscopy, this went up to 53%. So with no dermoscopy, tinea nigra was not considered in more than half of the cases. So the conclusion of the paper is the diagnosis of tinea nigra is improved by the use of dermoscopy. And let me show you an example here. This is a case courtesy of Natalia Jaimes, who is there with you guys. So this is a 12-year-old female. She was referred from an melanoma concern. The mother is an MD, so of course, threshold for concern is lower, right? So the mother was really concerned, asking us, do we need a surgical oncologist right away? That's my daughter needs a PET CT, right? And of course we say, well, let me take a look first, right? And this is a lesion on the sole, tiny lesion, right? This is the clinical photo, and this is the dermoscopic photos, right? And what you see here again is these fine wispy strands or pigmented spicules with no melanocytic pattern on the sole, right? And these pigmented spicules with these wispy brown strands is classic of tinea nigra. Case from our clinic, right? 25-year-old female. She went to Brazil with friends, had fun, and she noted this after a couple of months. Same story, right? These fine, wispy browns of pigmented spicules on the sole, no melanocytic pattern. But in this case, we did confocal microscopy. Look at the beautiful ephi here on the stratum corneum. So you know confocal microscopy is not good for acral sites, right? Because it's very thick skin and you never get to the dermoepidermal junction. But this is a corneal disease. So if you can see the corneal layer, you will use this confocal for the confirmation of the diagnosis. Another patient went to a Caribbean with this lesion here, same pattern. Fine, wispy brown strands of pigmented spicules with no melanocytic pattern, tinea nigra. What about now tungiasis, right? Tungiasis, again, is a disease caused by a flea, the Tunga penetrans, which is the smallest flea ever. It's very common in South America, very common in Brazil, and in some African countries. Again, with globalization, travels around the globe, is believed is 6% of all travel-associated skin problems, which is fairly relevant, right? Again, the female penetrates the human skin most of the time on the feet and starts feeding on blood and can live for up to 1 month. It causes itch, you can have infectious, tetanus, gangrene, etc. And this is the clinical appearance, right? It mimics warts, right? So differential diagnosis here is wart, foreign body, or tungiasis, but dermoscopy is so characteristic. I'm going to show you the comparison of the differential diagnosis. This, of course, tungiasis, wart with the interruption of dermatoglyphics, these thrombosed vessels, and the keratin, and this is just foreign body, right? On dermoscopy, you'll see the central pore, which is very classic, plus the X sometimes, and this peripheral ring here, classic of tungiasis here. So this is what you need to learn. Again, the central pore, the peripheral ring here, and sometimes the X. You know how this works. The flea penetrates the human skin, starts here feeding on your blood here. The rear end of the flea goes to the surface, and the eggs are secreted to the environment, right? And this cycle continues and continues. So remember, the gravid female is feeding on your blood here, and again, the rear end is eliminating the eggs. One more example here: this papule on the feet, and you have here the central pore, the peripheral ring here, and the eggs. Sometimes you have this horrible, revolting picture that I don't want to highlight here anymore, but you see the X. Very early case that came to our clinic here. So at first you don't see the classic papule with the pore, but you can see it's moving here. Look at it. If you are very careful here and you take your time, you see this moving around. Not good. Ticks now. We're almost at the end, right? So no worries. What about tick infestations? So ticks, again, very common in the US, not so common here in Chile, but you know, ticks are associated to other diseases, very common in the summer, Lyme disease, Rocky Mountain spotted fever, tick paralysis. And I just want to show you how you see this under the dermatoscope because it's fairly easy, right? You have this area here of erythema and you have the tick here. Very, very easy, right? And if you're going to read more, you have this AD, Derm World, featuring ticks, right? The size and everything. Let me show you just one case. This is a healthy male in his 30s. He came for a new mole. The lesion was itchy, was in the thorax. And in the ER, the doctor thought it was herpes zoster. So they started Valtrex and antibiotics. And you don't want to see why, right? This dermatomeric plaque here with this crust here. So herpes zoster, dermatitis. It's dermatomeric, so I would say herpes zoster. But take a look at that. Dermoscopy 1, 2, 3. 1 second diagnosis. Boom. This was not zoster, right? This was just a real tick here, feeding on the blood of this poor patient, right? So this was a tick bite with tick. And that's it with bugs. I mean, we're done here. But before I'm done, and sorry Natalia, if I'm a bit past over my time. I don't know if it was 20 or 30 minutes. Sorry about this. I want to show you other uses of your dermoscope. And yes, I am a surgeon, right? I do most surgery, and I use my dermoscope for margin delineation, for pre-surgical evaluation, but also for this, for removal of retained sutures, for removal of foreign bodies. And let me show you a case. This is a patient. This is the father of one of my best friends. I have done most surgery a couple of times for different BCCs. But this patient came to me this time for this new lesion, and I really thought this was a CC. He sent me a photo over the phone and say, bring your father to my office. And I thought this was keratin, right? But then I was looking carefully, and this keratin was moving, right? So I grabbed, I think it was a needle holder because it was very thick, and I grabbed this, or a forceps, I don't know what it was. And I took out this, and it was a thorn, right? The patient was, I don't know, gardening on the backyard, and got this. It was never an SCC. It was a foreign body, right? Or what about this patient here? Is this melanonychia, right? Could be, right? Melanonychia will follow up the patient. Could be melanoma. But take a look with your dermoscopy. It doesn't look like melanonychia. It looks like something under the nail, right? And yes, dermoscopy can help you remove this foreign body. This is my forceps here. It's not easy to understand the three-dimensional field when you're using the dermoscope. So this is a special adapter for suture. Look at that, foreign body removed, right? So we publish this. This is a spacer here, and an adapter for your dermoscope. So you put your scope, you place it over wherever you want to remove something, and then when your small forceps can go in here. So it's much easier. Again, a painful lesion on the sole. This could be a wart. This could be whatever. But again, it's foreign body. And this is thanks to dermoscopy. I grabbed a forceps, took it out, and it was a foreign body. But what is this? Looks like a leg of a insect, right? Of an ant or I don't know what, right? So this is a splinter, a metal, whatever. So the patient that night sent me a photo. It was just the hair of his dog, right? It was a beautiful pack, right? So it was Milo the Pug who was guilty of this. And this is funny because when I was doing this talk, I was like, does this have a name, right? And yeah, it has a name. It's cutaneous pilimigrans. So we name everything in dermoscopy. So this is exogenous hair from an animal or whatever. It's called cutaneous pilimigrans. So to finalize, we started like this, right? In 2025, this is not correct, right? In 2025, this is the way we examine patients with your dermoscope because we all love dermoscopy. So I hope you like this talk. If you have any questions, please don't hesitate emailing me. Thank you, Natalia. Thank you, the whole University of Miami team for inviting me. I hope you like this and hope to see you soon. Bye.